Welcome to The Explainer. Today, we're diving into a pathogen that is, let's be honest, probably flying under the radar in a lot of our labs, Corynebacterium urealyticum. We've used a comprehensive Gemini deep search to pull together this review, and it's really geared towards my fellow medical microbiologists out there. Trust me, this is one organism you're going to want to know more about. So, what's the big deal with this bug? Well, it really hits a trifecta of clinical challenges. First, it's incredibly tricky to diagnose using routine methods. Second, it's naturally resistant to a whole host of drugs. And third, it's a really serious threat in hospitals, especially for our most vulnerable patients. It's truly a pathogen hiding in plain sight. All right, first up, let's talk about the clinical side of things. Where does Corynebacterium urealyticum pop up, and what is it actually doing to the body? For a long time, this was just brushed off as another skin contaminant, a diphtheroid. But we now know its clinical impact is way more significant than that. The whole story of how this bug causes disease comes down to one single powerful weapon, its urease enzyme. And I'm not talking about just any urease activity. This thing is one of the most potent urease producers we know of in medical bacteriology. It's so strong it can kick off this dramatic chemical chain reaction right inside a patient's urinary tract. And you can see that whole process right here. That super potent urease breaks down urea into ammonia, which causes the urine pH to skyrocket, sometimes above 8.0. In that incredibly alkaline environment, crystals like struvite and calcium phosphate literally just fall out of solution. They then form these hard, almost plaque-like incrustations all over the lining of the bladder and kidneys, which is what causes its signature diseases, alkaline encrusted cystitis and pyelonephritis. Now, here's a really critical point. This is not a pathogen you see in healthy people. It's a classic opportunist. It goes after patients who are already vulnerable. Think long-term hospital stays, people with urinary catheters, or anyone who's recently had a urology procedure. And you know what really rolls out the red carpet for it? Prior use of broad-spectrum antibiotics, which wipes out all the competition and lets this highly resistant bug just take over. Okay, let's head over to the lab bench because this is where things get really interesting. We're going to see exactly why this organism so often slips right through our fingers in the daily diagnostic workflow. So you put it under the microscope, and what do you see? A pretty classic coroniform picture, right? Gram-positive, club-shaped rods, maybe in those Chinese letter or palisade arrangements. It looks familiar. But the real challenge, the part that trips everyone up, is what it does, or rather what it doesn't do on the culture plate. Now listen, if you take away only one thing from this, let it be this slide. Our standard 18 to 24-hour urine culture protocols will systematically fail to detect Corynebacterium urealyticum. It's just too slow-growing and finicky. After 24 hours, you're going to see one of two things: nothing, or these tiny pinpoint colonies that are so easy to write off as insignificant. To catch this bug, you absolutely need to incubate your plates for at least 48 hours, and honestly, 72 hours is even better. So let's say you've done everything right. You've held the plate and you've managed to coax these little colonies to grow. How do you actually confirm what you're looking at? The number one giveaway, the big, bright, flashing sign, is that incredible urease activity we talked about. You take a colony and put it on a Christian's urease slant, and it will turn bright pink, fast. I'm talking minutes to a few hours, not a day or two. That rapid, strong reaction is your biggest clue that you're dealing with Corynebacterium urealyticum. For a definitive ID, you have a few options. MALDI-TOF can get you there, but its accuracy is totally dependent on how good your database is and if you're using the right extraction method. 16S rRNA sequencing, as you know, can struggle to tell different Corynebacterium species apart. So really, if you want the gold standard, no questions asked answer, you have to go with RPOB gene sequencing. It just has much better power to discriminate between these closely related species. All right, let's move on to treatment. And honestly, this conversation is pretty straightforward because it's completely dictated by the organism's predictable and very, very extensive natural drug resistance. This table really says it all. You can just about throw the book at it. Beta-lactams, aminoglycosides, fluoroquinolones, it's resistant to pretty much all the standard UTI antibiotics. But, and this is the key, it is consistently universally susceptible to glycopeptides. Vancomycin and teicoplanin are the absolute cornerstones of treatment. Linezolid and daptomycin are also very reliable choices. Now, this resistance pattern creates a real headache for us in the lab when it comes to reporting. As it stands, EUCAST hasn't published any clinical breakpoints specifically for Corynebacterium urealyticum. That means we can't just report out an SI or R. The best practice here is to report the raw MIC value and then add a canned comment that guides the clinician, pointing them towards expert rules and the literature that shows glycopeptides are the way to go. And this quote right here shows why that guidance is so vital. Take the Dutch UTI guidelines, for example. They recommend drugs like fosfomycin or cephalosporins as first-line therapy. But as we just saw, Corynebacterium urealyticum is intrinsically resistant to all of those. So if we don't correctly identify it and guide the therapy, treatment is guaranteed to fail. It really highlights the massive impact our work in the lab has. And while it's not common, these infections can happen in kids, particularly those with existing urological problems. The game plan is exactly the same. It's all about the glycopeptides. The big difference, though, is that the dosing gets a lot more complicated. As you can see, it requires really careful calculations based on the child's age and weight, and it often involves therapeutic drug monitoring to make sure we're hitting the right levels safely. So when you add up all these challenges, it's hard to find, hard to identify, and hard to treat with standard drugs, it becomes crystal clear that preventing these infections from ever starting is absolutely the most important thing we can do. And prevention really comes down to the fundamentals of infection control. We're talking great hand hygiene, thorough environmental cleaning, and using contact precautions for patients we know are carrying it. But there are two things that are extra important here. First, a strong antimicrobial stewardship program to stop creating the selective pressure that lets this bug thrive. And second, strict, hardcore adherence to our CAUTI, or catheter-associated UTI prevention bundles. And that brings us to the big question, one that I think all of us in the lab should be asking ourselves. Given how slow this thing grows and how easy it is to miss, just how many cases are we inadvertently failing to detect with our standard 24-hour protocols? It really makes you wonder what the true prevalence of this pathogen actually is. And that's our deep dive into Corynebacterium urealyticum. If this got you thinking about your own lab's protocols, I'd love to hear about it in the comments below. Make sure you subscribe for more explainers like this one. And of course, for a complete list of all the sources we used in this analysis, you can find a link to the notebook document right there in the description. Thanks so much for watching.